Hi, I'm Dr. Abdulmalik Altaher. I'm General Dentist at the Shark Al Primary Care Center, Ministry of Health, Al Jawf, Saudi Arabia. I'm proudly graduated from College of Dentistry, Imam Abdulrahman bin Faisal University, formerly University of Dammam. Today I'm going to discuss endodontic diagnosis. My outline introduction, how to reach a probable diagnosis, diagnostic terminology. Historically, diagnostic classification based upon histopathological finding rather than clinical finding that lead to confusion and incorrect diagnosis. We have to establish an universal classification system to do proper pulpal and periapical diagnosis to determine what clinical treatment is needed and to allow communication between educator, clinicians, students and researchers. To do probable diagnosis, we have to take a medical history, dental history, check compliance with the patient, and we have to do clinical examination, radiographic examination, periodontal evaluation, and clinical testing. Diagnostic terminology made by American Association of Endodontists and American Board of Endodontics. We have pulpal and apical diagnosis. This is the pulpal diagnosis. We will start with normal pulp. There is no symptoms. Might respond to the cold test. Not more than 1 to 2 seconds after the stimulus. Reversible pulpitis, inflammation should resolve and pulp return to the normal following the appropriate management of the etiology. The pain is not spontaneous. Stimulus such as cold is applied and goes within a couple of seconds after removal of the stimulus. The etiology extends exposed dentine, caries and deep restoration. Symptomatic irreversible pulpitis, the vital pulp is incapable of healing and RCT is needed. Sharp pain, pain is spontaneous, no pain or discomfort with percussion, analgesics ineffective. The etiology is deep caries, extensive restoration, fracture exposing the pulpal tissue. Asymptomatic irreversible pulpitis, there is no clinical symptoms, respond normally to thermal testing but may have had trauma or deep caries that would like to be exposed following the removal. Pulp necrosis, death of the dental pulp and the RCT is indicated, not responding to the pulp testing and it's asymptomatic. No apical periodontitis unless the canal is infected. Previously treated, the tooth has been endodontically treated and canals are obturated. No response to thermal or electrical testing. Previously initiated therapy. The tooth has been previously treated by partial endodontic therapy by pulpotomy or bulbectomy. Respond to the pulp test depending on the level of the therapy. And we have now the apical diagnosis, normal apical tissue, not sensitive to percussion or palpation. Radiographically, it's normal. Symptomatic apical periodontitis, painful response to biting and or percussion or palpation. Inflammation of the apical periodontia. Radiographically, depending on the stage of the disease, there might be normal width of the periodontal ligament, or there might be a periapical radiolucency, and the RCT is indicated. Asymptomatic apical periodontitis, no clinical symptoms, no pain on percussion or palpation, inflammation and destruction of the apical periodontia that is of a pulpal origin, and there is an apical radiolucency, chronic apical abscess, little or no discomfort, inflammatory reaction to pulpal infection and necrosis which happened gradually, intermittent discharge of the pus through the sinus tract. There is a periapical radiolucency, acute apical abscess, spontaneous pain, extreme tenderness to the tooth, to percussion, inflammatory reaction to the pulpal and necrosis that happened rapidly, pus formation and swelling, no radiographic signs of destruction, condensing osteoitis, diffused radiopaque lesion, localized bony reaction to low-grade inflammatory stimulus usually seen at the apex of the tooth. This is my reference and thank you for listening.